Okay, good morning. Thank you very much for inviting me along, Chris and the rest of the team at Digby Brown. It's a real privilege and it's great to see such a full room. Hopefully I'll give you some useful information in this talk. So to start off, this year, 2024, is the 50th anniversary of the Glasgow Coma scale. The original paper was published in 1974, in July 1974 in The Lancet, and it's really a major achievement for neuroscience in Glasgow, for medicine in Glasgow, for Scotland as a whole. But let's start with something a little bit more philosophical. What is consciousness? I mean, we can define it simply through dictionary definitions, a state of being aware and responsive, someone's awareness or perception. But it's clearly much more than that. It's everything, every interaction you ever have in your life is through the medium of consciousness. So it's fundamental to all of us, and obviously it's been of great interest to philosophers and scientists, well, for as long as humanity has been around, really. I'm not going to go into this too much, but there are a number of theories of consciousness, some of the classical ones from people like Descartes and David Hume and John Locke, and they're complex, and frankly, when I read them, I don't really understand them. And of course, there are more modern variations in all these. But it's something that really has engrossed humans throughout history. Both scientists and philosophers and biologists and ethicists even involved in this area refer to the consciousness as the hard problem. Some people think it's a completely intractable problem, that it might not be possible for us to solve what consciousness actually is. I mean, on one level we know that, we know neurons have chemical transmitters, they produce electrical signals. We know that they interact with millions and billions of other neurons within the brain. But how does that actually generate consciousness? No one knows, is the truth. And both from the philosophical and the scientific end, people are still trying to tackle this problem. And it may be something, as I say, that we will never solve, or it may be something that in the future we'll have a much better understanding. But to keep it more mundane, more medical, more mechanistic, if you like, we do understand what consciousness is, at least on a sort of rudimentary scientific level. We know it's an interaction between the higher parts of the brain, the cerebral cortex, and the deeper parts of the brain, the reticular activating system, which is found in the midbrain and the pons and the upper brainstem. And you need both those parts to be there. And obviously there are numerous pathways and numerous signals, and there's complexity here. But effectively you need the interplay between the two to be conscious, to be awake. And then we've got the concept of coma. Well, coma just comes from the Greek word for deep sleep. And, it's very simply, it's an impaired consciousness, an inability to be awakened. And one of the difficulties is that throughout history and throughout medicine, there was always many differing descriptions of what this was, with no real objective, consistent, repeatable way of talking about it. And the idea came to Professor Teasdale and Professor Jeanette that maybe that was something that they could tackle. So all these words floated around, drowsy, stuporose, comatose, obtunded, and they were all peppered through the medical notes. And the truth is, there was no way of being absolutely sure that one person's obtunded was another person's comatose, and there was no reliable way of tracking changes in the patient over time. So, as I said, Professor Teasdale and Professor Jeanette decided to try and tackle this. And what they were interested in was looking at the degree and the duration of consciousness and looking at a way of mapping and tracking that was reliable and consistent and easily repeatable. And one of the lovely things about this is, especially in the world of high-tech medicine and clinical trials and things that are exceptionally expensive to do, really this was just two men with a notepad and a pen and lots of coffee probably, who obviously had enormous experience and insight into the problem they were dealing with, but really the practical scale, the Glasgow Coma scale, came from their observations as clinicians over time. So it was an innovation rather than an iteration, and that's something that I think is quite inspiring because we don't see that as much in modern medicine anymore. It tends to be an iterative process. So this is what they come up with, a three-part scale, looking at three domains: eye-opening, best verbal response, and best motor response. And just to look at those in a bit more detail, and I know many of you will be aware of this, but I thought it would be worth talking about, to look at the three different domains and what the breakdowns actually mean. So eye-opening's fairly easy to remember. You know, your eyes are open, as mine are now. That's spontaneous eye-opening. If someone is lying with their eyes closed, a patient, and you're not sure, you approach them, you speak to them. If they're not eye-opening, you maybe give them a gentle tap in the shoulder, and then the eye open. If they're not doing that, and you're concerned they're in coma, then you're looking at a painful response. And this goes against a lot of what we do in medicine. Inflicting pain just seems ethically and morally wrong, but for the purposes of conscious assessment, we have to do it. And the correct way to do this is actually to use supraorbital pressure. Most people have a little nerve, the supraorbital nerve, that sits in a groove, and you can apply your thumb to that. You can try it on yourself later on, or just now if you like. If you hold it there firmly for a few moments, it becomes painful quite quickly in most people. And most people will then wake up or respond and eye open their eyes. And then if people are in deep coma or unrousable, then there'll be no eye opening at all. The verbal response goes from completely orientated in time, person, and place, as hopefully I am and most of you are at the moment, to no verbal response at all. Interestingly, in terms of orientation, it's usually the orientation in place and time that go first, and people retain the ability to know who they are. So anything less than that is confused. You've got inappropriate words. Often you find it's swear words that people preserve the longest, and there are, believe it or not, theories that there are different parts of the brain that might contain the function for that. And often those are the first words to come back as well. And then you've got right down to incomprehensible sounds or no verbal response at all. And then to come on to the motor response, which is the most important of all, the most predictive. If you could only use one, this is the one you would use. From obeying commands right down to no motor response. Again, it's based on supraorbital pressure. You apply the pressure, and if an individual is localizing to pain, to make that category, the arm has to be above the clavicle, and attempt to swat the pain stimulus away. Anything less than that is flexion. You've then got this interesting category of abnormal flexion, where the hands kind of go into a spasm, and an extension where the arms are like this. Now, interestingly enough, on the original paper, the observant amongst you may have spotted, it was a 14-point scale, not a 15-point scale. And it was simply flexion, and it wasn't broken down into abnormal flexion and normal flexion. But they changed that because they realized there was a predictive value in abnormal flexion, and abnormal flexion implies what we call a decorticate posture, which means, again, you've lost the higher centres of the brain. It has a much poorer prognosis than simply flexing. And then, of course, extending is even worse than that, and in which case we refer to that as a decerebrate posture. Why is it 3 to 15? It's odd, isn't it? It starts at 3 and ends at 15. Why not? Why the no response is not 0? The answer to this is it comes down to technology in the 1970s, actually. And I heard this from Professor Teasdale himself. Basically, the software they were using didn't allow no entry or a 0 entry. So it had to be 1 for the lowest score. And that's why it's 1 to 15. The number of points and the other scores are just based on, I guess, clinical acumen and what was required. But the 3 comes from the need to put in a figure. There are special circumstances where it's more difficult to apply. Children, obviously, who might be pre-verbal, or babies for that matter. If the patient's intubated, you can't get a verbal response. They may have a focal neurological lesion causing a problem with speech. There may be a language barrier. They might be paralysed. Obviously, you can ask them if they are conscious enough to stick out their tongue or blink their eyes or something. And then you've got the very, the devastating locked-in syndrome, where there may be nothing but eye movements. And again, if you are astute and you're aware, then you can still assess consciousness just through the eye movements alone. What are the advantages of the Glasgow Coma scale? Well, it's very easy to use, it's reliable, it's repeatable. There's literally zero equipment required other than someone that's been trained how to use it. It's got low cost. It can be done anywhere in any medical environment or non-medical environment. So it's got exceptional advantages. There are some common misinterpretations. The fact that it was originally a 14-point scale and became a 15-point scale does lead to confusion. It's important to emphasise that what you're recording on the chart is the best motor response. So you do get situations where a patient might localise on one side, but they've got an extensor response on the other. And you record the best motor response in those circumstances. The word withdrawing is often used even in clinical practice, and that is completely ambiguous. It's not stated really in the original scale. And whenever anyone tells me that, I ask specifically, well, is it localising? Is it flexion? Is it abnormal flexion? Is it extension even? Because it could be all those things. And then you've got the pupillary response, which we'll talk about in a little moment. It can be applied really to everything that involves conscious level assessment, which is more or less all of medicine. So brain injury severity, trauma scores, revised trauma scores, ITU outcome scores, stroke scales, subarachnoid hemorrhage, everything. Almost all these severity scales incorporate either all or part of the GCS, sometimes just the motor score, but often the whole thing. So it's completely diffused throughout medicine. There's a brain injury severity, which again most of you will be aware of, that simply groups initial GCS into three categories and looks at mild, moderate and severe. Now the interesting thing is, what's the origin of this? It's difficult to actually find out where the origin of this is, but I think it was basically a consensus that developed over time following the introduction of the GCS. And it is useful, it's crude, but it is relatively useful. And then, of course, again, most of you will be aware of the Mayo classification, and a GCS less than 13 is incorporated there. Again, maybe not as granular as it could be, and we know that there are pluses and minuses with the Mayo classification, although it's still in wide use. The other interesting point that comes up is whether to sum the GCS or not. Now, it's very commonly done in clinical practice, so you'll even hear it in the television when there's a medical drama, someone's GCS 7 or GCS 12 or whatever. But actually, you do lose information when you sum it, and it assumes equal weighting between the three parts, which isn't true. So it's a little bit like adding apples and oranges. In the lower, if you've got a lower GCS, the motor score is dominant just by the nature of it, whereas the higher GCS is close to full consciousness. It's a verbal and eye-opening. And the culture in Glasgow, not funnily enough in other neurosurgical units that I've worked, but the culture in Glasgow was and still is very much not to use the number, certainly in the neurosurgical unit. And if a registrar phones me up and says there's someone GCS 9, I will ask as a reflex response, well, what does that mean? What are the breakdown scores? Because GCS 9, it's difficult to visualise what that is, but if you get the breakdown scores, you can see the patient that's localising, that's not eye-opening. Whatever, you can see it. So that's a really important point to make, that the summing up is useful for studies, but the breakdown scores for the individual patient are really important. Come briefly to pupillary responses. Now, the GCS isn't all-encompassing, and one of the other important things we look at in an unconscious patient is the pupils. We take a pen torch and look at whether the pupils are reacting to light or not. Now, if you've got a unilateral dilated pupil that's fixed dilated on one side, then what you're really concerned about is a mass lesion of some sort, a tumour, but more commonly would be a mass lesion from a head injury, such as an extradural hematoma, acute subdural hematoma, something like that. And then more worryingly than that, you've got bilateral fixed dilated pupils, which implies, well, it can be consistent with brainstem death, but it certainly implies something very serious going on. People can have bilateral fixed and dilated pupils from seizures, so it's important that it's something you check over time too. And the pupillary dilation occurs really because the mass lesion causes shifts in the brain. And if the lesion is big enough, as you can see here, there's an extradural hematoma. You get, first of all, subfalcine herniation across the midline, and then you get lateral tentorial herniation. And as it comes across the edge of the tentorium, it catches the oculomotor nerve, the third nerve, and it catches the fibres which cause the pupil to constrict, and that causes your pupillary dilation. And therefore, that's known as a localizing sign as well, something that allows us to know which side of the brain the lesion is on. But these pupillary changes, there has been a concept that's developed over the last 6 or 7 years, really, to try and modify the GCS, what we call GCSP. So it's a combination of the Glasgow Coma scale and the pupillary response. And there's a pupil reactivity score, which is very simple. If neither pupils both pupils are reacting, basically it's 0. If one pupil is unreactive, it's 1. And if it's both pupils are unreactive, it's 2. And you take that score off the GCS. So obviously, if pupils are unreactive, then you want your overall GCS score to drop to represent a more severe brain injury, and that's the concept. And it has been used. There was quite large data sets from the impact and the crash studies, which were large head injury studies. And GCSP actually maps very well with both mortality and unfavourable outcome. So this is something that might become a bit more prevalent in the future. Just wanted to discuss a few clinical cases briefly, because we all like stories and narratives, and I certainly do. And just to show you that we do really use the GCS every day, every patient. So this was an 80-year-old man. These are all my patients. These are all Glasgow patients, I should say. 80-year-old man, he had some headache. He did a series of falls. He was GCS 14, so confused. And he had a mild weakness. It should say right-sided weakness, not left-sided weakness there. The scan shows this large left-sided chronic subdural hematoma. And he had burr holes drained, so he had a couple of holes, small holes drained in the side of the head. And then the blood clot, which is liquid at this stage, is washed out. He was initially better, and then he deteriorated a bit again afterwards, which is not uncommon in this particular condition, and he needed a further evacuation. But ultimately, he made a good outcome. So that's at the milder end of the spectrum. He's only got a mild drop in his GCS. This is more severe. This was a 50-year-old man, alcohol on board, as is often the case with some of the more severe traumas that we see. He'd had a fall, very nasty fall. He was GCS 3. And he had fixed dilated right pupil. So that's a localizing sign due to the mass effect from the acute subdural hematoma, combined with the low conscious level. So he underwent a trauma craniotomy, and he survived. He's fully conscious, but he's been left with significant deficit and a severe left hemiplegia, and unfortunately, he's in long-term care as a result. This is another trauma case. This man was a 32-year-old Filipino sailor who was in a container ship off Scotland, and he had a head injury, had to be brought in by helicopter. He'd had a fall in the ship. He was GCS 7, so that's localizing to pain, no eye opening, no verbal response. And he had, rather interestingly, this, you can see the lens-shaped extradural hematoma in the left occipital region, with that's the coup, if you like, and then the contra-coup injury of the frontal contusions. And he underwent a trauma craniotomy for the extradural. We managed the contusions conservatively. He was a bit mildly confused afterwards, but he did very well, actually, and was fit to go home with help from the Philippine consulate a few weeks later. So even more severe case, 23-year-old, he'd fallen from the 3rd floor. He was initially GCS 11, so eye-opening to speech, localising, and a verbal response of sounds. Words. He was intubated and ventilated. He had a CT scan. On the scan, you can see there are some high-density areas on the back at the right there, some contusions. The ventricles are effaced. There's some frontal contusions as well. So it's got the appearance of high intracranial pressure. And he was accepted for transfer to our unit. He was initially hemodynamically stable. His pupils were reactive, but we put in an intracranial pressure monitor in the right frontal region, and his ICP was high. So despite the various measures, the non-surgical measures we used to bring that down, those were unresponsive. And therefore, we gave him some mannitol, which reduces the pressure momentarily, and took him for a repeat scan. And ultimately, he went for a decompressive craniectomy, where we remove a large portion of the bone at the front of the skull to reduce the intracranial pressure as a life-saving action. He spent a week in intensive care and then several weeks in the institute after that. And often these patients can be very disabled, certainly in the short and medium term and even in the long term. The other problem you've got is there's a big hole in the head, which is obviously unsightly, and patients don't like it. It's very disfiguring, and they want it sorted out as soon as possible. Plus, you can get neurological effects, syndrome of the trephined. There's always a concern that that you've got the brain effectively exposed, and that there could be a further injury, although the risk of that is actually quite low. But as much as we can, we try and repair that defect as early as we can. And we do so by putting in a titanium plate. Sometimes we use the autologous bone flap that we've put in a pocket in the abdomen, but in this case we used a specially manufactured titanium plate, as you can see there. But as you might expect, someone with that severity of injury, he's not fully independent. He's got significant difficulties. He's still got seizures, unfortunately. He's never going to work again. But in some respects, and this is where it gets ethically difficult, some trials would say that's a good outcome, he's survived. But we have to think carefully about what a good outcome is. So that's how we use the GCS on a day-to-day basis. This is Richard Dawkins, who came up with the concept of a meme, which is the cultural or ideological equivalent of a gene. And it's the idea that in the same way that genes transmit themselves, so can ideas. And that maybe the ideas undergo a form of, natural selection, trial by fire, if you like. And I think that this is the more you think about this, the cleverer this becomes. A good idea, or an idea, any idea, even a bad idea, will be subject to scrutiny and dissection and torn apart and reformed and come back as a better idea or just die out. But good ideas are robust and they last and they fend off the attack, if you like, and often become stronger over time. And I really think Glasgow Coma scale is a strong example of an idea that really has stood the test of time. What is the future of the GCS? Well, there's a huge unmet need in global healthcare, particularly in sub-Saharan Africa, but in other parts of the world too. I was out at an exam as an examiner in Ethiopia in December, and there were a number of neurosurgeons in training who were sitting their final fellowship exam there, and most of them were excellent. We passed, amongst others, we passed 2 Malawian neurosurgeons, and that meant that they had literally doubled the number of neurosurgeons in the country. And I think, that's a country with many millions more people than Scotland in it. And I think that's just one example of just how unmet the need is, particularly in trauma on a global scale. And given the money, the distances, the lack of infrastructure, often transport's one of the biggest problems. The need for low-tech, low-cost, practical solutions is there. It's required more than ever. And the Glasgow Coma scale certainly fits into that category. At the bottom there, that's Lindy's Delicatessen in New York. Lots of comedians used to gather there and chat and throw ideas back and forward. And one of the concepts that came out of those discussions was the idea that a non-perishable thing, an idea, maybe a building, maybe an institution, it doesn't have the lifespan that we as biological organisms have. Is that the older we get, our lifespan reduces effectively. But ideas and non-perishable things, sometimes their longevity actually increases over time. And again, I think the Glasgow Coma scale fits into that. We are actually running a 50th anniversary event to celebrate the Glasgow Coma scale. That's going to be on Thursday, the 27th of June at the Royal College of Physicians and Surgeons in Glasgow. Digby Brown have very kindly sponsored this event. There'll be a number of academic speakers from around the UK and further afield. Sir Graham Teasdale will be there himself. So it'll be really a one-off event to mark an historic achievement. There's an online option if anyone's interested. You're very welcome, or to come in person. The seats are limited. And thanks again to Digby Brown for having me along, for supporting GCS 50, and thanks to the Royal College and Greater Glasgow and Clyde as well. Thank you.
Thank you so much, Chris. So we have time for a couple of questions. If anyone would like to ask any questions. Yes, Liam?
You know me, I can't keep quiet. Chris, thanks for such an elegant and interesting talk. I was just thinking as you were talking about global healthcare, another Glasgow development recently has been the use of vCreate. I'm not sure if you know about vCreate, but Samir Zaberi, who's one of the paediatric neurologists, has been working with vCreate, and it's a clinical portal where you can take a video. So the neurologists are using it for seizures, so anyone in the world can upload this photo of a seizure. Yeah. And then a neurologist anywhere can just say, yes, it's epilepsy, no, it's not, etc., etc. And they're also working on AI algorithms that can be used to make diagnoses. Do you think something like a video of someone in a deep coma state could be, you could use that for a GCS rating for non-experts, if you've not got anyone with a neurological training, but you could take a short video, upload it. Do you think that could be useful in that kind of global healthcare context?
Thanks for the question, Liam. Yes, I think there's huge untapped potentials. The problem, certainly in Africa, is actually it's the infrastructure. So a lot of the places that need the healthcare, you're not going to have a mobile phone signal or Wi-Fi or internet at all. So that's the real, actually the biggest effect in global healthcare in Africa would be building more roads probably to allow people to get to the centres where they can have healthcare, any kind of healthcare. But I think over the next decades, hopefully, it will be rolled out, and certainly the technology is part of the solution, but the biggest problem is probably manpower actually and low-tech things.
Thanks, Chris. Any other questions? You've got off lightly here. Right, so if you'd like to put your hands together again for Chris, that would be great. Thanks.
Thank you. Thanks.